Now we have a very important session with a very important and elegant speaker, Professor Colin DayanC from UK Cardiff University. We have the pleasure of having Professor Colin with us today. Really, he's a pioneer in his field because every research on type 1 treatment or delay of type 1 treatment, when I try to read this research, I find the first one in front of me, Professor Colin DayanC. Let me give the mic to Professor Magdi.
Okay. Thank you, Professor Ines. And actually, it's my utmost pleasure to introduce my mentor, Professor DayanC. I'm considering myself lucky to work with Professor DayanC and with his guidance and supervision at Cardiff University on distant learning. It's a great pleasure today to hear from Professor DayanC. Professor Colin DayanC is a professor of clinical diabetes and metabolism at Cardiff University, UK. His research focuses on the immunopathology of type 1 diabetes, and he leads early phase clinical trials for antigen-specific immunotherapy. And he's going to talk about today a state-of-the-art lecture, novel and future therapies, screening and prevention of type 1 diabetes. Please, Prof.
So thank you very much. Assalamu alaikum. It's a pleasure to be here and have the opportunity to speak to you in person. It's not been so easy over the last few years. So today I'm going to, well, what might seem like science fiction, but we're going to go into new realities around type 1 diabetes, which I hope you will find an exciting journey. So the title is Screening and Prevention of Type 1 Diabetes. And here are my disclosures. So I want to just remind you that type 1 diabetes is not a metabolic disease. We treat it as a metabolic disease because we don't treat the disease itself. We just wait until it burns out and then put on insulin. And we've been doing it for 102 years. But here it is. We can have an islet here. Don't know what this shows up. This is the brown is the insulin, red is glucagon. And here is the infiltration, the insulitis. These are T cells that are infiltrating the pancreas, and they destroy, selectively destroy the beta cells. They don't hit the glucagon secreting alpha cells, just the beta cells, which is intriguing in itself. And you end up here with an islet that has no insulin, has only got glucagon. We know that's the underlying process. So the thinking is, if it's not a metabolic disorder, it's actually an autoimmune disease. Well, if we can slow or halt the autoimmune process, we can delay or even avoid the need for insulin altogether. Fairly obvious, but let's see how we can do this. So one thing that I found quite helpful to think about, here is this is from the National Pediatric Diabetes Audit. So that's all the children in England and Wales. So it's about 29,000 children, this data. And it's cross-sectional data in the first year after diagnosis, 1 year, 2 years, 3 years, etc. And you can see that when the children are first diagnosed, they all have pretty good blood sugar control. And I think you have that experience yourself. When people are newly diagnosed, they have good, fairly easy blood sugar control. But then it gets more difficult over time. And particularly here in the teenagers, it goes up. Now, why does it go up? Have they forgotten what we taught them? Do they not know what to do? Have they got tired of the treatment? Well, we don't think that's the reason. The reason is that here they have some beta cell function, and then they're losing it over the first 5 years. So that last few islets, those last little bit of beta cell function, is really helping them get much better beta cell control, glucose control, and particularly in people where they find it challenging. Now, many of you may have children of your own, and you have teenagers, and you know teenagers don't always do what they're told. And for those people, they find it challenging to do all the things required for insulin. It is the most difficult drug we ever ask people to do. It changes every day, many times a day. You know, it's not like a GLP-1, which is pretty straightforward. So the thinking would be, if they're losing their beta cell function here, if you could put it back, then, or stop it happening, then wouldn't everybody have good glucose control? Wouldn't that be a good place, or stop the disease at this stage? So the first bit of thinking is, if we can stop further loss of beta cell function when you're diagnosed, and we estimate you have about 20% left, we could help people's control for longer. Okay, so now I know you all enjoy the immune system. You remember it from your medical school days, and one or two of you like me, it was a few years ago since you were in medical school, and I'm afraid a lot has changed in immunology, but it's a very exciting area. So it is a complicated system, I accept that, and I'm not going to give you an immunology lecture today. What I want you to see here is these gray boxes here. These are not parts of the immune system. These are drugs or biologics. And we have over 50 of these now that can pick out little bits of the immune system, not the whole thing, not destroy it, but take little pieces out, which means you can do it much safer. So when we think about immunotherapy, a lot of people in diabetes, because it's not something we do regularly, we go, oh, this is terrible. We're going to expose our patients to a lot of risk. But I think you're thinking then of general immunosuppression here. The thing we use for transplantation, sure, that's a risk. Those people get opportunistic infections and, you know, have increased rates of malignancy, and they're high, the risk of side effects is high. This is not what I'm going to talk about today. This is not what we're going to do. This is worse than insulin, so we're not going to do that. But there is selective immunosuppression, those little boxes, ticking off, taking out little pieces of the immune system. And when we look around us to our left and right at the other specialties, everybody is doing it. So in arthritis, in skin disease, in inflammatory bowel disease, in neurological disease, in multiple sclerosis, all of our physician colleagues are doing this, but we're not. And we have an autoimmune disease too. So what that is telling us that these drugs are low risk, and I'll show you a bit more about that over time. The last line we don't have yet. But the idea here is that we could re-educate the immune system to the antigens on the beta cell. And we say, look at this, don't react to it. I like to call that an unvaccine, because we know about vaccines, you give a protein to protect, to get an immune response against that and protect against smallpox or COVID or whatever it is, very selective. Can we not do the opposite and give un-COVID or un-smallpox to get that? We don't know quite how to do that yet, but there's quite a lot of work in that area. And that will be very low risk because we're only affecting that very small part of the immune system reacting to those antigens. So let's look at psoriasis. And this is a disease I love to hate. And the reason is they have lots of drugs and we don't have any, right? So, I mean, which is a worse disease? Is psoriasis worse than type 1 diabetes? What do you think? I'm not going to ask you if I have a poll, but, and yet they have 11 licensed biologics. Anti-TNF, and these on the IL-17 system over here. So if they can do it in skin disease, maybe we can think it's safe to do in diabetes. If you go into rheumatoid arthritis, it's crazy. They have over 50 licensed therapies, all sorts of different. Can you see these different things that are being targeted by monoclonal antibodies here? And then they have other drugs, the JAK kinase inhibitors, and more being developed further along the line. And they've been doing this for over 30 years. In fact, I did my PhD in the laboratory where they developed anti-TNF. At the time, I thought this was going to be very dangerous. And I said to my mentor, don't do this. It's going to be very dangerous. I wouldn't do this. And of course, it became the biggest selling drug of all time in terms of grossing costs. So maybe I should have had shares in that, but I didn't at the time. So there are treatments that are effective to slow the autoimmune process in type 1 diabetes. We haven't tested so many. We haven't tested as many as in psoriasis or rheumatoid arthritis or inflammatory bowel disease. But there are 10 now where there's some evidence of benefit. But you'll be aware that not one of them is actually licensed for new onset type 1 diabetes. I'm going to come back to some of them as an example. Just give you some examples. Here is anti-TNF. I mentioned anti-TNF as being developed many years ago. This is one of those, golimumab. It's a monoclonal antibody. You give it subcutaneously every 2 weeks. 1 dose, standard dose. How much easier is that than insulin, right? Here we're giving subcutaneous 4 times a day and adjusting the dose. This is a standard dose. And you can see here we measure C-peptide. So that's the endogenous production of insulin. This is the placebo. So these are people with newly diagnosed within a couple of months of diagnosis. They're losing beta cell function. The C-peptide is declining. And those that received the golimumab, it didn't decline. Certainly over the first year or so, declined much less. And I just introduce another one. This was just published just less than a year ago. And this is a tablet called baricitinib. Maybe you've come across it. It was actually used during COVID as a treatment for the immune reaction in COVID. So over 1 million people have had baricitinib. And in terms of anti-TNF, hundreds of thousands of people have had golimumab. So we know a lot about the safety of these drugs. This drug is very interesting because it affects the action of interferon. And interferons act on the islet to make them more susceptible to destruction. So it was really actually targeting the islet as well as the immune system. And the colleagues in Australia did this study, and you can see, again, same idea, C-peptide. Here's the placebo, which is declining over the first year. Here is the baricitinib, 1 tablet a day with preservation. And we just recently published this study on a drug called ustekinumab. You have to learn all these words, don't you, that you haven't used before. This is a drug, again, for psoriasis. It's been there for over 15 years, and it's licensed down to the age of 12. I won't show you the data, but it was quite slow in working. It took over 6 months, but after 1 year, there was a 50% preservation. So it wasn't perfect, but it was helpful, and it was illustrative of very selective treatment, because this just picks out a very small percentage of T cells. It's about 1 in 1,000 of the T cells that is targeted by ustekinumab. And the important point about that is it makes it very safe. And I just want to illustrate it here. So what I've drawn here is a risk of being admitted to hospital for a severe infection, for a septicemia, not just a urinary tract infection, a severe infection. And if the control, the background population is here, if you have those drugs that I'm not using, the renal transplant drugs, the risk is 10 times higher. But notice that the risk is also high in poorly controlled diabetes. You know this. People with high blood glucoses, they have more infections. And it's about 7 times higher, their risk of septicemia. If you just have type 1 diabetes itself and it's quite well controlled, it still is higher. It's about 3 times higher. So what about these drugs? What risk, if they're affecting the immune system, what risk do they put you under? Here they are. They're lower than the risk of the diabetes themselves. Ustekinumab was the one I was talking about before. We could see almost no difference from control in terms of any side effects. Anti-TNF, it's slightly increased, a slightly increased risk of tuberculosis. But the risk is still a lot less than the diabetes itself. So I'm just taking some time to try and convince you that this is a safe thing to do for your patients, not a dangerous thing to do. And now I just want to introduce this tablet. I'm not sure if you've heard about this, but you will all know of verapamil. It's a cardiovascular drug. We've had it for 50 years. It's used for angina and for arrhythmias. What am I talking about this? This is not an immune therapy. You're right, it is not an immune therapy. But what it seems to do is act on the beta cells. This is a beta cell here. And it reduces the inflammatory pathway. This is an inflammatory pathway through a protein called TXNP. And inflammation is induced either by high blood glucose or by cytokines acting down this pathway over here. And so verapamil seems to protect the beta cell. It doesn't stop the immune system, but it makes it less, the beta cell is less susceptible. And this data was first published by Aneth Shalev in the United States. So here, again, C-peptide over here. Patients given verapamil, it almost seemed to increase their C-peptide from diagnosis. If they stopped it after a year, it declined, and here was the control group. And just as an illustration, this is the insulin use, as you might expect. If you're losing beta cell function, as in the black line, you'll need more insulin over time. That's what normally happens from diagnosis. But when they took the verapamil, the increase in insulin was much less, was flat. And there's been a second study. Most people didn't believe that study. They said, that's ridiculous. How can a cheap tablet like that be effective? So it was repeated by an American group, and this is now in children aged 7 to 17, and they gave them verapamil. Actually, it was a 2-by-2 study of closed loop versus verapamil. And the closed loop therapy didn't preserve beta cell function, but the verapamil did. And you can see it here in the bottom over there. So you can see that the level of C-peptide at the beginning was almost the same as the level at 1 year. And we are just repeating that now. This is our recruitment curve. We finished recruiting in April of 2024, 135 patients to an adult study of verapamil versus placebo, and we'll have the results in Q2 of 2025. So hopefully we'll confirm that verapamil is effective. But we want to move this forward a little bit. So we've started what are called platform trials. So they've been doing this for a long time in cancer. You do 3 things at the same time. Why do 1 at a time? So this platform trial, which is going to start next month, everybody gets verapamil as a background. Some people get verapamil plus golimumab, that anti-TNF, or verapamil plus that tablet, baricitinib, or verapamil plus this, which is called thymoglobulin. It's injections over 2 days, all of which have been shown to have an effect themselves, but the 2 together may be even stronger. So this is the way we're trying to accelerate the whole process, learn more quickly of things that are effective but safe. And just for anyone who's interested in clinical trials, you save, of course, because we're sharing the controls. We don't have to have the same number of controls for each one. So if you just did 1 versus 1, you need about 32 patients in each group. If you do 2 studies, you only need 46 controls. If you do 3, you only need 56. So here you're saving, and if you do 4 at the same time, you save 64 patients you don't need to have in the trial because you can share those controls. So less patients means quicker trials. Well, okay, you might say to me, hang on a minute, we don't need this, right? We've got the fancy pumps you just heard about, and they work really well, which they definitely do work really well. Do we need new treatments? Well, let me take you back to the story here. So I've been talking about an autoimmune process, and I've been talking about people at diagnosis. But we now know that's not when the disease starts. The disease starts a long time before that. So this is what we sometimes call the Eisenbart curve from George Eisenbart. And here's the amount of beta cells. You'll start with 100% of beta cells. But when you first come to the doctor and you say, I'm drinking a lot and I'm losing weight and I'm thirsty, I'm passing a lot of urine, you've lost 80%. So it's now called stage 3. It's quite a late stage. And we talk about 2 stages before that. Stage 2, when you have 2 or more antibodies to the pancreas, so we know the autoimmune process is present, and you're dysglycemic. So it's like impaired glucose tolerance. And by that time, you've lost probably more than 50%. Or stage 1, in which you have 2 autoantibodies, but you're normoglycemic. But as I'll show you, we know that those people are all going to get type 1 diabetes in the end. They're all going to lose all of their beta cell function. So why do we need to wait for it all to be destroyed? Especially is because we don't know how to put it back. When we've lost it, we've lost it. So here's some of the evidence, as you may know. These are studies done over 20 years showing if you have 1 autoantibody or 2 autoantibodies or 3 autoantibodies here, this is the percentage that don't have diabetes. And you can see these are children predominantly, and this is time over in years. Gradually, you can see that if they have 2 or 3 autoantibodies, by 15 years, over 80% of them have already progressed to needing insulin. And look at that curve. It looks like it's going to hit the bottom line. So we estimate that 80 to 90, probably 100% of these people are going to progress to type 1 diabetes. So we're good at predicting. If you have 2 or more antibodies, not the red line with 1, but 2 or more, then you're going to need insulin. And when you are dysglycemic, so these are people who are dysglycemic, like impaired glucose tolerance, and these are normal glucose tolerance. When you're dysglycemic, it's coming close. It's very close. It's going to happen soon now. You can see in this case, if you're dysglycemic, almost all of them are going to have diabetes, need insulin within 5 years. Whereas if you're normoglycemic, it may take longer than that. So it's official, if you haven't seen it. If it's on the American Diabetes Association, it's got to be official, doesn't it? There are 3 stages of type 1 diabetes. Stage 3 is what we're used to, but there is a stage 1 and a stage 2. So, putting all the things I've just said to you together, why can't we treat earlier? Okay? if we treat before they need insulin, maybe they won't need insulin. Why do we wait until they're newly diagnosed? So this was the idea of treating them, for example, at stage 2. We know they're going to get it. Let's get in early if we think the treatments are safe. And you'll be aware that the classic case of this was Kevin Herald's study in 2019. At the time, everybody thought he was a bit crazy to use an immune therapy on young people who are well. They had no symptoms. Why are you giving them an immune therapy? Because it's going to happen. So he used this drug called teplizumab, which is an antibody to CD3, to the T cells. It's on that list of the 10 that I showed you at the beginning. He'd already shown that it works in newly diagnosed, but he's going into the stage 2. So this was a course of 14 infusions. It's really only one treatment, but they have to fractionate it because otherwise you get cytokine release syndrome. So it's done over 14 days, but that's it. That's the end of the therapy. No more treatment, nothing else. You can't get it out. It's in there, right? There's no compliance issue after that. So that was over this time here. And again, this is the proportion who are free of diabetes. Here's the placebo. And these were stage 2, so they're dysglycemic. You remember I said it takes them about 5 years to develop diabetes. That's exactly what happened. After 5 years, 60 months, 80% of them had developed the need for insulin. But of the ones given teplizumab for 14 days and nothing else, nothing happened over that period, over the 5 years, now only 50% needed insulin instead of 80% needed insulin. And on average, it was calculated that it slowed the need for insulin by about 32 months, so nearly 3 years. How does it work? Well, actually, we don't know exactly how it works. But what it seems to do, so here are beta cells, and the red are now the autoreactive T cells. These are the ones that are destroying the beta cells. The idea is the antibody binds to these, and it doesn't kill them altogether. It doesn't remove all the cells, but it makes them into what's called an exhausted phenotype, where they can't do anything. They circulate, but they don't do very much. And this resets the balance of the immune system. In terms of side effects, during the infusion, you sometimes get a skin peeling like this, but it disappears after 12 to 14 days during the period. And this is because of the release of cytokines as some of the T cells are killed. This is really intriguing. If you look at the T cell levels during teplizumab, do you remember I said it was a 14-day infusion? And here's the T cell level. This is placebo. It goes down, which is what you'd expect because it's an anti-T cell drug, but it's coming back up even before we finish the infusions here. And so it seems that it doesn't destroy all the T cells. It marginalizes them. Some of them leave the circulation and then come back. And it means that after 1 month, the level of T cells is normal. It's almost back to normal. And there is no evidence of increased infection risk beyond that period. There is a little bit of infection risk, for example, herpes zoster, during this period. But after that period, and they've done some follow-up for 4 years with a related drug, 7 years with this drug, as far as we can see, they are not chronically immunosuppressed. So don't worry that they're going to have an infection 3 years down the line. That's not what we see. We've reprogrammed rather than destroyed the immune system. It doesn't last forever, though. As you've seen, it lasts for about 2 or 3 years. So it's now been marketed in the USA. November 2022, it was licensed in the first, an absolute landmark, the first time that immune therapy was licensed for type 1 diabetes, but not for newly diagnosed, but for stage 2, which you know now is the prevention stage. It's not licensed for new onset, and we can discuss why it happened that way. So there it is. It's available. It's now available in UAE, I think, and a couple of other countries, and they're working through to other approvals. So in our consortium, our research consortium, we like to say this: we're moving towards insulin-free T1D, which is a funny idea, really. We always think about insulin-dependent diabetes. That's what we call juvenile onset, insulin-dependent diabetes. But can you have type 1 without insulin? Yes, because it's an autoimmune disease. If you treat the autoimmunity, you don't need the insulin. And I want to emphasize this in a different way. You're all very familiar with insulin. You've used it all your lives. You think it's an easy drug. You think about maybe as a safe drug. I quite want to get you to hate insulin. I've done insulin all my life as well. But just think of the people who've had severe hypoglycemia. I've had patients who've died of ketoacidosis as well as hypoglycemia. It's a very difficult drug to use, and it's not a safe drug to use either. So think about what it means to have not need insulin for 2.5 or 3 years. People say, oh, this drug, 3 years without insulin. Oh, you know, what does that matter? Just bring it on. Well, during this period, you have no hypoglycemic risk. As I teach my students, diabetes doesn't cause hypoglycemia. The treatment for diabetes causes hypoglycemia. If you don't need it, you have got no hypoglycemic risk. And you have no lifestyle limitation. You don't have to think about your exercise, what you eat, blah, 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 blah. The first patient I ever had who had a pancreas transplant, I said to him, hey, what's it like? What's good about a pancreas transplant? Because he was off insulin. And what do you think he said? Was it the finger pricks? Was it the insulin injections? No, he said, I can eat what I like. And it's really striking that these lifestyle limitations we take for granted, but to think about what you're eating every day is really a lot of pressure on people. And of course, you don't even need to monitor because nothing's going to happen. You can't go hypoglycemic. Maybe you monitor every 2 or 3 months in case the effect is wearing off, but not every day. And most importantly, during this period, you have near normal glycemic control. So you're not increasing your risk of metabolic complications. In fact, you're saving. I think of it like pensions. You put money or investment, put money at the beginning when you're diagnosed. It protects you for many, many years. And we saw that with DCCT, didn't we? If you have good control over the first 7 years, you have less complications 30 years later. So it's money in the bank here. And of course, improved quality of life. So I'm very keen that 3 years is not nothing, but we can do more than that. So that's treating them here. It is also something else you get. So this lady is crying, and she's crying because her son died at diagnosis. And it happens about once a year in the UK that people don't realize they have type 1 diabetes. Maybe you've seen it yourself. It doesn't get recorded in diabetes because no one realizes they had diabetes, but they present with ketoacidosis very sick and sometimes too sick, and it's too late. And this is the rates of ketoacidosis here. And I think it's probably the same in your country. It has not changed in 30 or 40 years. In fact, it got worse during COVID. About 25% of children are in ketoacidosis at the time of presentation. They are late presentations. Well, if you're trying to detect people early by screening, then you don't get DKA because you know it's going to happen. You pick people up and you say, you're going to get diabetes over the next few years. And they say, okay, all right, I'll watch out for it. And I tell them what the symptoms are, and it doesn't happen. So, for example, here in the DAISY study, only 3% were admitted to hospital instead of 44%. And these are 3 screening studies. Again, DKA rates are dramatically reduced. This is not the treatment, but it's the screening and the preparation that reduces this problem. But screening, looking for patients that you could treat early is hard work. And that's because the rate in the background population is 0.3%. So in Frieda in Germany, they screened 90,000 children. And you can see here that 89,000 were negative, 310 were multiple antibody positive, very important, 2 or more antibodies. Of those, most of them, about 80% were in stage 1, about 10% were in stage 2, and interestingly enough, 10% of them already had diabetes. Technically, on their glucose tolerance tests, they had diabetes and they didn't know it, but they would have done over the next few months. So it's hard work. It's a lot of people to identify what you want. Now, a lot of people say to me, well, just don't do this because you're making everybody terrified. They're really scared. You say you're going to develop diabetes, you have the antibodies, they're going to worry for all those years. Well, it's not what the data suggests. Yes, these are measures of worry. This is the mothers, these are the fathers. And here is the control, so background people who don't have diabetes, the worry level in the parents. And yes, they worry more. The fathers worry less than the mothers. But in about 6 months, the worry goes down. They say, look, okay, all right, I've got used to the idea. And in the end, they say the experience of diagnosis was much less of a shock. It's a terrible shock when your child is admitted to hospital. You thought you had a healthy child. They get sick. What's going on? Sometimes nobody realizes. They say they have cancer or something. They're losing weight. In hospital, in intensive care, it's a real shock. Whereas here, it's information, but the child is never ill. And when they get closer to needing insulin, you can start insulin as an outpatient and do it gently. You can have education over several months. You don't have this time of sickness. So there is anxiety, but I think overall it's less. So a lot of people are trying to find ways of screening the population because although relatives, first-degree relatives, have 10 times the risk. So it's more like 3% in first-degree relatives, 1 in 30. So you say in the family you've got a 1 in 30 risk. But outside of that, it's 1 in 300. But as you're probably aware, most people with type 1 diabetes have no family history. So 90%, it's not like type 2, 90% comes out of the blue. 90% comes from the general population. So if we just screen the relatives, we're going to miss 90% of the cases. So now we're trying to look at ways to screen the general population. There have been some guidelines about this and some guidelines about what to do when they're positive. These were published this year by a consensus guideline from JDRF or Breakthrough T1D. What do? We check the antibody again, we follow them up. And then when that's the case, then we monitor them, for example, with HbA1c every 3 to 6 months. There's some discussion about how you monitor them. But there's some quite good guidelines now in place once people are positive, because it may be several years before they actually develop the diabetes. Okay, for the last few minutes, I'm going to take you to the next level. So these are, there's one treatment licensed. There's another 8, 9, probably another 20 actually in preparation to be licensed. And those are for this, right? So delaying onset of diabetes. And maybe we can delay it more and more and more and more. So I say it's an exciting time because look at here, we have the artificial pancreas that we learned about. Here's immune therapies. But what about this, which is the idea of stem cells? And we can definitely do this now. We can take cells and convert them into beta cells. And this was one of the first studies, but at the ASD in Madrid 2 or 3 weeks ago, Vertex announced they've had 14 people treated with stem cells. So these are not transplants, they're making them from a cell line, and 10 of them were off insulin. So the cells are working well. But they require immunosuppression, because although they're not a transplant, they're somebody else's cells, and you will reject them. So it's not quite perfect, we need to get around that. But this was also presented in Madrid, an incredible thing where they took, this is in monkeys though, they took the islets and they knocked out the HLA class 1 and class 2 genes, which are the genes that signal to the immune system. And it made them like an invisibility cloak. The immune system couldn't see it. They couldn't see these islets, and they put them back in the monkeys, and they got very good C-peptide levels, and they got normal glucose levels. Now, whether we can do that in human islets, we'll wait and see, but that's an islet transplant without immune suppression, which would be amazing. And of course, this is trying to do it, if you can do it from stem cells, you don't have to wait for people to die. You can just, ring up the company and they send it bacteria that are in your body. And people are talking about different probiotics that might be used at this stage. And let me tell you one more thing that you might find intriguing. So if your mother has type 1 diabetes, your risk of diabetes is about half what it is if your father has type 1 diabetes. They're both passing the genes on to you, so why would that be? And even more interesting, that only works if your mother had diabetes when you were in utero. Okay, so if your mother had you when she was 18 years old and she developed diabetes when she's 25, you don't get that protection from that mother. But if she was diagnosed at the age of 12, she has to have had her diabetes while you were in utero. If this makes sense. So what is that? And we got a little bit of an early information that we think it's to do with the glucose control. And it results in a paradoxical situation in which if you control, it seems that the higher glucoses in the mother protect the baby. And the way they do this is probably, I'm guessing now, they stimulate the pancreas of the baby. You know, when the mother has high glucose in pregnancy, you get a big baby, right? We know that. And that's because the glucose crosses to the baby, and the baby makes a lot of insulin. So the mother's glucose is increasing the strength, if you like, the growth of the baby's pancreas. So ironically, we get into the situation where, of course, we tell mothers, you must have very tight glycemic control in pregnancy, of course, because otherwise your baby will die or it will have congenital malformations and so on. But maybe that increases their risk of type 1 diabetes many years down the line. Now, I'm never going to say to a mother, don't control your blood glucoses because of the risk, because the risk is much higher to the baby now than it is in time. But if we understood that mechanism by which the glucoses have that effect, maybe we can do the same thing. So in utero, that we would give a treatment that would protect the babies for a long time to come. So these are just ways of thinking about getting in very early. They may not be reversing the diabetes, but preventing.
Thank you very much, Professor Colin, Dayan. And on behalf of ASD and the board of ASD, we are very happy and honored to have you as an eminent speaker. Thank you very much. And we hope to have you in coming conferences. Can you join me, please? Thank you. Thank you very much.